us at the other end. Would you pass that down? We're going to turn next to Dr. Art Kaufman. He's the Vice Chancellor for Community Health at the University of New Mexico Health Sciences Center. He's both an internist and a family doc. And the list of innovative programs that he's put together at the university is as long as LeBron James's arms, I think. One of those innovative projects is the development of health extension rural offices, and we've asked him to tell us a little bit about those offices today, among other things. Dr. Kaufman, thanks so much for joining us.
Thanks so much, Ed. Well, I wanted to talk to you about two programs you probably don't know much about, but we think are very important. Both of them are in the Affordable Care Act. They're buried in there, Section 5405. But actually, we've brought these up, and they've had a very powerful impact on our state. And we think this has implications for rural health across the country as well as in urban areas. But we think that they are addressing big challenges we have, especially in academic health centers. And those challenges are that almost all the training and role modeling are in big centers in big cities. And when you look at the health team, it's far too narrow to address the kinds of problems faced in rural America. And then when you look at the impact of our health system, we're shocked to find it only has an impact maybe on 10 or 15% of what makes communities healthy. We are just missing the boat. And that's why with all the money we spend in healthcare delivery in the United States, it has such a little impact commensurate or not commensurate with the amount we're spending. So we decided to have a radically different vision for our whole health science center to address the rural and urban health crisis we face in our state. And we came up with this challenging and, as you can see, competitive vision. And it's with our academic health center. We'll work with community partners to help New Mexico make more progress in health and health equity than any other state by 2020. The challenges out there, our chancellor is terrified. We've only got 7 more years. Are we making progress? You can imagine. So I have to answer this every day. And what's interesting is the operative word, health. It's not just health services. It's all those things that underlie health. And some of the biggest things that underlie health are not really the lack of doctors and nurses or the presence of them or pharmacists or OTs or PTs. It's the social determinants. Adequate housing, access to food. We're just talking about food deserts, stress, exclusion, social exclusion, educational attainment, transportation. All of those things have a huge impact on health. And I'm going to give you an example. In New Mexico, if you look at deaths from diabetes in our state, the Native American population has the best screening and treatment for diabetes of all ethnic populations in our state. And yet, they have the worst health outcomes, the highest death rate from this disease. Why? It's not because the screening and treatment is bad. It's because it comes too late. It can't make up for the fact of decades of poor nutrition, high stress, very low educational attainment, poverty, all of those social determinants. So if we're going to make an impact on our state, and this is true of every state, how is all the money poured into the health system going to be shared with those who actually impact social determinants? So we looked around and we found one of the best models is in the agricultural extension service. Now it's a different sector. Now we're talking about agriculture, but we're in health. But when we look at agriculture, these cooperative extension agents, they deal with economic development. They make sure farmers have greater crop yields. They help their youth graduate from school, do better through their 4-H clubs. They help proper canning for safety. They help improve nutrition through lots of nutrition classes. So we decided we're going to copy them, steal their name, and run off and have health extension coordinators. And now we have them all over our state. And their primary role is to link the community's health priorities with the health science center's resources. Move the locus of control out of the health science center towards the community. It's been very successful. They not only help make those programs respond to communities' priorities, but they monitor what's happening. And now we have these in different parts of the state, and they'll do all kinds of things. For example, they help with reducing opioid treatments. They find that one of the biggest problems in rural New Mexico, besides primary care, are dental problems and especially behavioral health problems. If you're in a small town and you have a behavioral health problem, are you going to go to your local behavioral health provider with a sign and everyone drives by and says, whose car is that? So the problems of access are huge. So they've been training all over the state, lots of lay first responders, lay people in mental health first aid. It's another response. They've set up telepharmacy to keep pharmacies going. They do a lot of work in trying to get kids to stay in school, graduate, and go into health careers. If you look at the number one employer in some of our rural communities, it's the health system. In Taos County, 65% of the new jobs were in health. And if you can get a doc to go to a rural town, they hire 18 people directly and indirectly. They generate $1 million in business. So it is a huge economic driver, a big social determinant, just like educational attainment. The success of this has led us to develop health hubs, academic extension hubs, where it's not just the provider, it's also linking with community colleges, federally qualified health centers, local hospitals, civic organizations, where now we have memorandums of agreement going out with all of those. And when you have a hub like that, it's attractive to health professionals to be recruited and to stay because they have professional and social bonds, reducing isolation. So that success has been enormous. Then to track what is the outcome. We often spend a lot of time training, and when people finish our training in nursing and pharmacy and medicine, OT, say goodbye, have a great life. It's not good enough. We want to know where they're going and whether they're meeting state needs. So we track in every single county for a population of, let's say, 56,000, how many docs, nurses, pharmacists should there be compared to what they have? For that gap, are we responding? Are we connecting with all the other training programs in the state? So we're beginning to develop that response, and that's been powerful. And then we want to know, how do we actually measure ourselves against other states? And this is just an example. You could look at something like primary care providers per 100,000 population. And in New Mexico, back in 2010, we were like 113.6. Well, if we want to jump 3 states worth, we've got to train and deploy 50 other primary care docs. It's quantitative, a social determinant, educational attainment, and high school graduation rate. We're one of the poorest in the country. We would have to train 1,500 more, graduate 1,500 more kids from high school to jump 3 states worth. So we're making it very quantitative so everyone can see, like on a temperature chart, whether we're getting closer and closer. Now, the one newer growing part of our health team that does most with social determinants are community health workers. And what was interesting about this is all of our health extension coordinators train community health workers. And it's in the Affordable Care Act. And what we're finding is managed care has bought these up. They pay us to train and deploy them, and they're decreasing substantially hospitalizations, ER visits, unbridled use of medications, because they're doing a lot of personal training about how to use the system better and addressing social determinants like transportation and other issues. So that is a growing concern. And finally, what is most interesting to make the circle come back together again, instead of just stealing Cooperative Extension's name, running away and putting it in health, we're actually now working with Cooperative Extension. And I was interested in the former panelists talking about the need for outreach and informing populations about how important it is to get insurance, whether it's Medicaid or subsidized through the exchange. As it turns out, we just got the state's grant to do that work with Cooperative Extension. They're in every county, we're in every county, and together we're sending messages out. It's not just for the new people who are now going to become eligible because of the Affordable Care Act. It's because 30% of the current uninsured people in our state who are eligible for Medicaid are not on Medicaid. There are so many barriers that we have to work with that population as well. And then in our primary care clinics that are so desperate to have, for their chronic disease patients, to have, for example, nutrition education. Cooperative Extension is now helping our primary care clinics, nutrition classes, they're helping them grow food, we got bees going, the aviars, they're selling all kinds of products, they're doing economic development around the primary care clinics, mostly federally qualified health centers. So I think there's a model that's developing that we would love to share. Thank you.
Thanks very much, Art. By the way, what are OLAS that were listed under economic development?
The Spanish word, olla. So what they are you can see them. It's the one with the tag on it. They're kind of clay pots, and they're porous. It's an ancient kind of irrigation. It has a very narrow neck. You stick it in the ground, put water in it, so the neck is so narrow it doesn't evaporate, but it irrigates about a foot around, and that's how you grow little plants.
All right, then.
$10 an oya.
Great, thanks very much.